Well, good morning, everyone. Happy Friday. Thanks for joining us today. Special welcome to all of our guests from East Coast, West Coast, and international. My name's Laura Fisher. I'm a bariatric surgeon at the University of Oklahoma in Oklahoma City. And on behalf of ASMBS and the Bariatric Surgical Training Committee, I'd like to welcome you to this session of the Fellows Project. My co-moderator today is Dr. Scott Shakora, Director of the Center for Metabolic and Bariatric Surgery at Brigham and Women's Hospital in Boston, Massachusetts. And the afternoon session today will be moderated by Dr. Julianne Lloyd, an assistant professor and bariatric surgeon at Baylor College of Medicine in Houston, Texas. Your regular moderators today are out taking the focused practice nation exam. Some reminders before we get started. Just so everyone knows, this is a special session where we bring together prominent speakers from the bariatric world on the first Friday of every month with lectures that are targeted towards fellows and trainees. And these lectures are delivered both live and on the ASMBS website without password protection. And if you are interested in applying for a bariatric certification through ASMBS, these lectures will count towards your didactic requirements. Please use the Q&A to ask your questions on the Zoom application rather than the chat section. And we will try to get to as many questions as possible at the end of the session. We will have a separate live Q&A session this afternoon for West Coast participants. So with no further ado, our topic today is nutritional guidelines and complications after bariatric surgery. I'd like to introduce both of our speakers. Our first speaker today is Dr. Rickesha Wilson. She is a metabolic surgeon and researcher at the Cleveland Clinic in Ohio, where she also completed her bariatric surgery fellowship in 2021. She is originally from Texas and completed her surgery residency at the University of Connecticut. Outside of work, Dr. Wilson loves great food, sports, and nice views. And Dr. Wilson will be presenting on nutritional complications after metabolic surgery. And then our second speaker today will be Dr. Nina Crowley. And Dr. Crowley is a metabolic and bariatric surgery dietitian and program coordinator at the Medical University of South Carolina in Charleston. She's been in the field of bariatrics since 2007. Nina is active in several obesity-related professional groups and loves networking and communicating with colleagues about appropriate communication, behavioral change, nutrition, weight bias, and advocacy. She can be found tweeting at psychodietitian, which I love. And her presentation will be called Nutritional Considerations in the MBS Patient. So Dr. Wilson, if you would like to go ahead and get started, we are very excited for your presentations today.
Excellent. Can you see my slides?
Yes.
Okay, wonderful. Well, good morning, everyone. I'm delighted to be presenting to you again. I'm Rickesha Wilson, and I'll be talking on the topic of nutritional complications after metabolic surgery. I have no disclosures. So for an overview, we'll review some anatomy and absorption, just some basic principles and how that may change after metabolic surgery. And then we'll talk about the clinical manifestations of short-term and long-term complications after surgery for our patients. And then we'll, of course, discuss some surgical treatment options and certainly things we need to consider in patients with nutritional complications. So this illustration highlights the GI tract in a linear fashion, and it really highlights how each portion of the GI tract contributes to nutrient absorption. And so important for metabolic procedures, of course, is that they oftentimes exclude the duodenum and proximal jejunum, and that plays a critical role in many of the nutritional changes we see in our patients after surgery. And so a lot of the protein, vitamins, and minerals that our patients are taking for supplements are usually absorbed in the duodenum and jejunum, but there are several factors at play along the GI tract. So of course, these are the kind of the current metabolic procedures that are done today. The sleeve gastrectomy is mostly restrictive procedures, but the others, the bypass, duodenal switch, SADS, and one anastomosis bypass, and others are malabsorptive procedures. So there's some gastric reduction or restriction, as well as a malabsorptive component where the small intestine is bypassed. So this picture of the standard Roux-en-Y gastric bypass highlights how each component has metabolic benefits. Those are in the green boxes, but also contribute to nutritional complications in the tan boxes. So focusing on nutritional deficiencies, starting with the gastric pouch. So of course, there's excessive decreased caloric intake, sometimes food intolerance, and so this can manifest complications for the patient, of course, when they can't comply with vitamin and supplementation. So you can get deficiencies, especially vitamin B1 malabsorption, and there can be serious consequences that we'll talk about later. And then food that makes it to the alimentary limb or the Roux limb in the gastric bypass, they don't have exposure to the biliopancreatic enzymes to digest nutrients. And so this leads to undigested nutrients that contribute to glucose malabsorption. And since bile salts can't provide the sodium that's needed for the glucose transporters to work effectively. And we see dumping syndrome from rapid delivery of nutrients to the alimentary limb, and syndromes like hyperinsulinemic hypoglycemia as well. And then, of course, the excluded stomach and the biliopancreatic limb, once again, cannot take part in digestion until they reach the common channel. And so you have malabsorption of multiple nutrients that can occur. And lastly, changes in the microbiome. While they can be beneficial, there can be some complications such as small intestinal bacterial overgrowth that can be seen in the excluded limb, vitamin K malabsorption that can develop due to microbial changes as well. So each component of these malabsorptive and all the procedures contribute in particular ways to nutritional complications. So of course, in the short term, we'll review some symptoms: nausea, vomiting, diarrhea, constipation. These are common things that we see in our patients. We'll go over some thiamine deficiency syndromes and dumping syndrome as well. So for nausea, vomiting, it's important to assess hydration in our patients and provide opportunities for IV hydration. Many programs may employ outpatient hydration centers for patients to go to avoid readmission. It's also important to inquire about eating behaviors. Some patients are drinking too much, too quickly. This can lead to nausea, vomiting. And of course, vitamin and mineral intolerance can lead to certain deficiencies, in particular thiamine. But also in the short term, it's also important to think about acute surgical complications that may need to be corrected. And so work up with the appropriate testing. Upper GIs, endoscopies, CT scans are always important to employ when appropriate. Diarrhea also can take place because of partially digested nutrients, because of the changes in anatomy. Sometimes you have dumping syndrome, so that can cause diarrhea. Certain medications we may put patients on, such as ursodiol, to prevent formation of gallstones. This can cause diarrhea. So really knowing kind of the anatomy, what was the common channel length, if it's a malabsorptive procedure, that may help you discern whether this is just loose stools that'll get better and normalize over time versus diarrhea that may be persistent, where we need to support our patients a little more aggressively. And patients can keep a food log, of course, monitoring food behaviors and treating any intestinal bacterial overgrowth syndromes with antibiotics are also appropriate. And of course, constipation can be caused and perpetuated by the opioids postoperatively that our patients get, PPIs, calcium, iron, and then elimination of caffeinated beverages in the diet can also have a constipating effect for patients. So stool softeners, laxatives, making sure patients stay hydrated, fiber supplementation, physical activity are all important to help with that. So we can discuss thiamine deficiency. This is something that everyone should really have in the forefront of their minds, short-term and long-term for our patient population. This can lead to serious and life-threatening consequences. Of course, thiamine is involved in a number of metabolic pathways, and it has a short half-life, only 10 to 20 days. And so patients, especially with nausea, vomiting, poor compliance with supplementation because of early intolerance, can really quickly become thiamine deficient. And of course, thiamine is absorbed in the duodenum and proximal jejunum, which is bypassed in many of the malabsorptive operations. So it's important to treat empirically with IV or IM thiamine when patients are struggling. This can prevent irreversible neurologic damage, and it's really hard to give a thiamine toxicity. So it's really worth it to just treat these patients, even if you don't have a level on hand or you're waiting for results to come back. In severe cases, you can do a bit of a taper, 500 IV for 3 to 5 days, then 250, and then there are oral options as well. And for recurrent cases, antibiotics for potential small intestinal bacterial overgrowth can be employed. And these are some of the clinical syndromes and ways thiamine deficiency can manifest. So you have dry beriberi, which refers to the peripheral neuropathy changes. You can have loss of tendon reflexes, paralysis, muscle weakness, numbness, tingling. Wet beriberi refers to the cardiovascular manifestations, so heart failure, edema of the extremities, tachycardia. And then bariatric beriberi refers to SIBO that we talked about that can limit thiamine absorption. And then gastrointestinal symptoms, and then Wernicke's encephalopathy, which refers to the central nervous system involvement. And so the triad for that is confusion, ataxia, and ophthalmic manifestations like nystagmus. And this can lead to coma and death in patients. So, and it's really important. There can be permanent consequences such as psychosis, amnesia. So a quick case report. It's not just malabsorptive procedures. Even after a sleeve, you can get Wernicke's encephalopathy. So this is a case of a 20-year-old woman who was 3 months status post a sleeve gastrectomy. She had a rapid weight loss, so 83-pound weight loss in 3 months. BMI was 48, and she had presented to an outside hospital for over 3 different times for 6 weeks with nausea and vomiting. And she had vision and hearing difficulties, but that wasn't really ascertained until later on in her course. But eventually she was diagnosed with gallstone pancreatitis, and she underwent a laparoscopic cholecystectomy on day 8 of this current admission. The next day, she became markedly less responsive, although she was moving her extremities. So an MRI was obtained and showed an acute infarct. And so she was intubated, transferred to a higher level facility. There, she had multiple electrolyte derangements, as we see in our patients, but they were aggressively repleted, and thiamine was also repleted, although it took 3 days for this lab result to come back at this higher level facility because it was a send-out lab. But nonetheless, her thiamine level came back as 29, and the lower limit of the normal range was 66. So certainly a manifestation of Wernicke encephalopathy. And so once the patient was extubated, she was noted to have nystagmus, dysarthria, bilateral upper extremity ataxia. And this is just an illustration of the different types of nystagmus: horizontal, vertical, rotary. So the patient had mild symptom improvement, but she did have some permanent neurologic changes. And she was eventually discharged after some inpatient rehab to an outpatient facility. But this is just one case report of how serious thiamine deficiency can be and the consequences our patients may suffer. So dumping syndrome, this refers to symptoms and signs that occur when food reaches the small bowel too quickly. So symptoms can occur early, about 30 to 60 minutes after meal, or late, 1 to 3 hours after ingestion. But the pathophysiology differs between these. So for early dumping, the arrival of hyperosmolar contents to the jejunum or the alimentary limb causes an intraluminal fluid shift and a release of several gastrointestinal peptides. And so symptoms include vasomotor as well as GI symptoms. So you have flushing, low blood pressure, tachycardia, palpitations, sweating, and even syncope. And then abdominal pain, diarrhea, nausea, bloating are symptoms that patients experience. In late dumping, so the rapid absorption of glucose induces an exaggerated insulin response, and that leads to hypoglycemia. And so that's kind of the hallmark difference between early and late. And those symptoms include palpitations, perspiration, tremors, aggression, weakness, confusion. Oftentimes patients feel like after a meal, they need to lay down, they're feeling fatigued. So syncope. So of course, this can be very debilitating, especially in a professional setting. So patients really, it's really important that we kind of treat and correct these syndromes and the causes. So the first step in doing so is you can do confirmatory testing, but the first step is dietary measures. So measured smaller meals throughout the day instead of larger meals fewer times is the first step. Then followed by medications that can kind of inhibit or slow down carbohydrate ingestion or digestion, such as acarbose or octreotide can contribute to slowing gut motility and slowing the release of gastrointestinal peptides that lead to these syndromes. And then lastly, surgical options can be explored, including reversal or correction of the anatomical issue. Pancreatectomy is not done kind of in recent years, but that has been explored in the past. So there are a variety of ways that long-term complications can manifest in our patients. So these constellation of symptoms are caused by various combinations of nutrient and mineral deficiencies. For example, glossitis and loss of taste can be due to iron, vitamin B12, vitamin A, zinc deficiencies, whereas edema can be due to severe protein malnutrition, thiamine deficiencies, selenium, vitamin B3. And in severe cases, liver failure, heart failure can contribute to the edema as well. So let's just explore a few of these manifestations of long-term complications we can see. So iron deficiency, anemia. Iron deficiency is one of the most common deficiencies in patients presenting for weight loss surgery, and everyone should be screened for this. So we know that iron is essential for the production of hemoglobin, and therefore iron deficiency results in a microcytic hyperchromic anemia. Mechanisms driving iron deficiency include reduced iron intake and then reduced tolerance to iron-rich foods. And then decreased exposure to hydrochloric acid in the stomach is needed to convert the ferric form of iron that's found in the diet to the ferrous form that can be absorbed. And so bypass of the primary absorption sites for iron, which are the duodenum and proximal jejunum, contribute to a deficiency as well. And then of course, reduced surface area for absorption, depending on your common channel length as well, can contribute. So symptoms include fatigue and weakness, depression, pallor, syncope, hair loss, nail spooning or colonychia, leg cramping, lightheadedness, loss of appetite, and then pica. So eating ice, kind of clay, dirt, but oftentimes we see people eating a lot of ice. So that's a manifestation, but it's important to remember to do a thorough workup for patients to rule out other causes as appropriate, such as GI malignancies, maybe a GJ ulcer, that may be bleeding, diverticular disease. So appropriate testing should be performed when clinically appropriate. Then vitamin B12, also known as cobalamin. This is a cofactor involved in DNA synthesis, and it plays an important role in metabolizing fatty acids and amino acids. Hematopoiesis and neurologic function are also dependent on adequate vitamin B12 stores. So vitamin B12 is bound to protein from our diet, and it requires hydrochloric acid and pepsid that's produced in the stomach to be released from that protein that it's bound to. It's then bound to intrinsic factor, also produced in the stomach by parietal cells, and is then transported to the terminal ileum where it's actively absorbed. So therefore, vitamin B12 deficiency can be seen in all types of bariatric operations because there's decreased exposure of dietary vitamin B12 to hydrochloric acid, pepsid, and intrinsic factor. So vitamin B12 is stored in the liver, and it can last about 3 to 5 years. So deficiencies may take several years to develop without appropriate supplementation. So symptoms can include megaloblastic anemia, leukopenia, thrombocytopenia, infertility issues, glossitis, paresthesias, balance issues, ataxia. There are multiple symptoms that can manifest. And then measuring metabolites such as homocysteine and methylmalonic acid may be more specific markers. And folic acid supplementation can oftentimes mask vitamin B12 deficiency too. So that's something to consider. And then of course, assessing vitamin B12 status annually in our patients is important. And next, talking about metabolic bone disease. So calcium and vitamin D deficiencies are among the most common deficiencies in our patients. And so metabolic bone disease is one of several manifestations of this. So calcium is, as we know, is critical for normal physiology in the cells. So it's absorbed in the duodenum and proximal jejunum, and it's regulated by vitamin D, parathyroid hormone, and calcitonin. So as this picture illustrates, low calcium levels stimulate the release of parathyroid hormone from the parathyroid glands, and this stimulates the release of calcium and phosphorus from the bones. Also, 25-hydroxy vitamin D stored in the liver is converted to 125-hydroxy vitamin D in the kidneys, and this stimulates the small intestine to increase calcium absorption. So many factors as listed here lead to metabolic bone disease, and there's evidence of early bone remodeling and bone loss as early as a year after surgery. However, fracture risk increases many years after surgery. So it's important to annually measure these levels, encourage our patients to exercise, get sun exposure, and then follow guidelines in terms of bone density testing as well. Intestinal insufficiency or failure is a condition marked by the intestine's poor ability to properly digest food and absorb nutrients. So severe protein malnutrition is a hallmark sign with related gastrointestinal symptoms. So risk factors are those who have excessive weight loss, have undergone malabsorptive procedures with long biliopancreatic limbs, so maybe 150 centimeters greater, or short common channel lengths, maybe greater or less than 150 centimeters. And some patients have suffered complications from metabolic surgery, such as intestinal necrosis because of volvulus or internal hernias that may have been treated in a delayed fashion. So there are various treatments to support these patients, especially in intestinal failure centers, but it's important to exclude other causes of malnutrition, such as hypercatabolic states, bowel obstructions. If there's a short common limb that's contributing to diarrhea, antidiarrheal agents may work, but considering corrective or reversal surgery may be life-saving for these patients. Offering pancreatic exogenous enzymes due to exclusion from the BP limb. Treating small intestinal bacterial overgrowth with antibiotics to help with absorption and digestion, and then enteral or parenteral nutritional support are all ways to help patients with intestinal insufficiency and failure. And then a spectrum of neurologic disorders related to nutrition can be seen. In our patients, studies report up to 16% of patients can have neuropathies after surgery. So peripheral neuropathies are the most common. This can manifest as memory loss, weakness, gait instability, and confusion. And this can be caused by thiamine, vitamin B12, folate, and copper deficiencies. Polyradiculopathy, it resembles Guillain-Barré syndrome, but there's no respiratory dysfunction and the CSF is normal. And you can diagnose this with EMG and measure thiamine as well. Usually that's a deficiency. Peroneal neuropathies manifest as foot drop, fat pad loss, and can be due to multiple deficiencies. Optical neuropathies are due to vitamin A and B12 and copper deficiencies. Other myelopathies, copper and vitamin B12, and then progressive peripheral neuropathies are due to multiple deficiencies. So anytime patients manifest these symptoms, it's important to measure these levels to see how we can replete them. Altered nutritional physiology may lead to renal stones. So normal calcium and oxalate from our diet forms an insoluble salt. And so it's poorly absorbed and moves through our system. But after metabolic surgery, calcium is saponified with fats due to fat malabsorption. And so thus oxalate is absorbed in the colon and then filtered through the kidneys, where it complexes there with calcium and can form calcium oxalate stones and can cause subsequent renal damage and, of course, a lot of pain and trouble for morbidity for patients. And so ways to manage this: avoiding dehydration in patients, maybe employing a low oxalate meal plan. Oral calcium supplementation can help, and potassium citrate can act as a competitive binder for calcium in the kidneys, so oxalate calcium stones won't form, and probiotics could play a role in altering the microbiome. But we can see that in some studies, oxalate excretion has been measured to double after bypass procedures, and the risk increases after 1 to 3 years. Cholelithiasis risk increases after surgery with rapid weight loss. And so really some risk factors that contribute are biliary stasis. So due to that excluded biliopancreatic limb not seeing nutrients, that can be one mechanism. Also, if you do like a pars flaccida technique, transected vagal branches can contribute to low cholecystokinin release and decreased gallbladder motility as well. And also fat malabsorption and fat breakdown from peripheral fat stores as you lose weight can increase the cholesterol saturation index in bile. And so this can all lead to cholesterol stones. So the highest risk from some studies is 6 months, but in a median of 3 years, the risk of needing a cholecystectomy is about 7 to 10%. Ursodiol is often prescribed, I know in our practice, for 6 months for those without gallstones to prevent the development. And then a cholecystectomy sometimes at the time of surgery can be done if patients are symptomatic or they have a lot of stones or concerning on their ultrasound. That is an option as well. And so also it's important that we think about surgical complications that can lead to malnutrition that we as surgeons have to always think about. So gastroduodenal stenosis or ulcers may require revision. Small bowel obstructions may need to be dealt with. If a patient has severe GERD and they've had a sleeve, maybe they need a conversion to a Roux-en-Y gastric bypass, or they may have a hiatal hernia. The pouch may have crept up into the chest. Gastric fistulas may require takedown. If there's a large pouch, revising that is an option. If there's a misshapen sleeve, re-sleeve versus a conversion to a bypass could solve that. Short common channel may require lengthening for better absorption. And then candy cane syndrome may require resection. Chronic pain due to internal hernia should be considered, and defects closed on diagnostic laparoscopy. And then patients with severe malnutrition and tractable symptoms may require reversal of their anatomy. So these are just some pictorial representations. So anastomotic strictures, you can do balloon dilation as a conservative management, but this is how it looks on upper GI. And after balloon dilation, you can kind of help symptoms. Of course, marginal ulcers can be diagnosed on endoscopy and treated with medication and follow-up endoscopy to ensure healing. And this is important, but marginal ulcers can, of course, stricture, cause bleeding and perforation. But this can all lead to nutritional issues for our patients. And then, of course, internal hernia. So depending on how you do your bypasses, retrocolic versus anticolic, you have more potential for internal herniation with the retrocolic technique. The Peterson defect, the JJ defect, as well as the space in the transverse mesocolon. And so making sure to close defects can, at the time of the index operation, is important because your hernia rate can go from 12% to 2% based on the literature. And then again, for reflux or misshapen sleeves, you may have antral dilation, retained fundus, a sleeve dilation overall. This may require conversion to a room-wide gastric bypass to help patients' nutritional status. Gastric fistula, again, this is just a pictorial example, and fistula takedown may be necessary. And then reversal of bypasses. So oftentimes you can just resect the roux limb and do a gastrostomy between the pouch and the remnant. Or if there's a long roux limb and you want to incorporate that into the common channel, then you can do a proximal resection and then incorporate part of the roux limb distal into the common limb. And you can reverse that way and then reconnect the pouch and the remnant stomach. So that was really just touching the surface. There are so many manifestations that our patients can deal with because of nutritional deficiency. So it's always important to be vigilant and think about the possibilities and know the pathophysiology as well. And with that, I'm happy to stop and hand it over to Dr. Crowley.
It was an excellent presentation, by the way.
Thank you so much.
Okay, well, who still wants to do bariatric surgery after all of that? Did our participation drop off? Hopefully not. All right, you guys are seeing my slides?
Great.
Perfect. Well, hey, everybody. I'm Nina Crowley. I'm a dietitian by training, and I have a PhD in health psychology. And then I've been using my PhD in psychology over the past few years to help manage our surgeons or run our bariatric program as the coordinator. So I have looked at some of the participants on here, and I do see kind of a few of my colleagues in integrated health. So some dietitians, some program coordinators. And so I'm hopeful actually that they can participate too in some of the Q&A. Admittedly, I've been doing more program coordination than dietitianing lately. So hopefully some people who are seeing all of this every day can really join in and help participate. But I wanted to kind of share a little bit of a unique perspective on the nutritional side of things. My only disclosure is that I presented a topic in this category for Medtronic probably over a year ago, so that could probably drop off. But I think, when I hear all of that science and the real surgical side of the complications, like I said, I think that's it's intimidating. And I know, patients are getting a lot of that when they're Googling complications of surgery, when they're having conversations with people who's had someone who had as we used to say, bypass gone bad. They're hearing a lot of that negative. And so in that beginning part, when someone's really considering surgery, I view all of this as really part of our surgeon's job to help with informed consent. So, I know we rely on our surgeons to do a lot at that first visit, but I think part of that is really expectation setting and talking to patients about what the possible risks are along with the benefits. I think different folks, balance the pros and cons of surgery differently, but this is really, to me, part of informed consent. For those of you who know me, I'm a huge fan of implementing shared decision making as part of your practice. And the best place to do that really is when you're talking to patients about even which surgery to consider and some of the pros and cons of them, including the nutritional complications. I do want to say, you know, with all of that said, I'm also a big fan of including your interdisciplinary team, and in this case, especially your registered dietitian. So if you're a fellow and you're, you know, about to get into practice, I think you're probably going to a program that's been established and not starting up a new one, hopefully. And you know, you can be assured that if it's an NBSA QIP accredited program, you have to have good dietitian support. And so there, you know, I could talk about that. I will talk about that some here, but I do want to make sure that, you know, all of that stuff that, you know, seems complicated or nuanced, or gosh, if it's, you know, especially iron. I mean, if someone could come up with like a beautiful iron treatment algorithm that worked for all patients, that's where it's at. It's so complicated. And I think a lot of it takes really a balance in sort of meeting your patient where they are and including the right people on the team. So, you know, I'll talk about that a little bit more as we go. And monitoring and surveillance, you know, long-term, some and most of these, you know, nutritional complications really come longer term than at the very beginning. So, you know, you have your early ones, those are probably the more objective and easier to spot and be aware of, but the longer term complications or deficiencies in vitamins and minerals really require kind of seeing your patients back to identify them. And so we know, you know, across the board, our long-term follow-up is pretty poor, and especially with the nutrition and the behavioral health visits, it can be pretty embarrassingly low in programs. So I would also say part of your nutritional complication pathway should be figuring out how to keep your patients in your pipeline so that if they are far out from surgery, they're, you know, have a way to reach back out to you, and they're not, that you did your job in the beginning and didn't make it so much about weight that if they regained weight, they are embarrassed or, you know, afraid to come back and talk to you about that. So, you know, these are all things I think to consider as you're setting up or, you know, moving into a program. And then, of course, I think this non-judgmental culture where you're really promoting a comfortable environment, ability for patient to share struggles. It's not just, here's your diet, here's your meal plan, here's your vitamins. If you're not taking it, you're a failure. And it's much more of a, you know, this is a hard thing. I mean, I listened to that list of all the complications, and when you see, you know, all the vitamins, it's complicated, even for people who are in this field. So I think sharing that it's not super easy to stay the course. It's not just following X, Y, and Z. I think that as a culture can really be helpful with your patients. So with that said, I am going to primarily share the information from the 2016 clinical guidelines for micronutrients, because that's probably our best at this point in time kind of go-to document for how to practice clinically. So again, as a dietitian, I like to remind everybody that, you know, it is evidence-based here that you include medical nutrition therapy by a dietitian on your interdisciplinary team, and they will be doing, you know, all of this stuff you won't even know, you know, the assessing, diagnosing, intervention, monitoring, and evaluation. That's part of a nutrition care practice that we learn in our training and that we apply to our patients who have surgery. Assessment, both pre-op and post-op screening, supplementation, repletion of micronutrient deficiencies. That's a big part of what your dietitians are doing. And then education at the outset and long-term on those expected deficiencies. So I tried to, I think all of this is quite complicated, and I don't think looking at it from here's the nutrient, here's the either the screening tool, the repletion, or the signs and symptoms. I almost feel like we need to flip that. Like when you're seeing this symptom, think this, test this, and treat with this. I didn't have time to put all that together like that, but I do think we sometimes go and have charts and things that are real nutrient specific, but then when you're with an actual patient and you're hearing their kind of generalized symptoms, it's hard to figure out which one that could be. And it kind of could be all of them, and it could be something unrelated. But, the paper here kind of breaks them into water soluble, fat soluble, and minerals. So this would be screening tests. This is all of the ones that are recommended in this paper, screening tests for the different water soluble vitamins. And just like we said, with learning all of the nutritional complications, with screening tests, it's going to be pretty dependent on your center, your availability for testing, the cost. I think ideally we would be testing, more than we probably can, but then there's a lot of, insurance doesn't cover this or that. You've got to use certain, codes to associate that with a deficiency, and they don't have a deficiency. And so there's a lot of other factors that go into what you're testing, other than what's the right test to identify that exact deficiency. So again, I don't think anybody at this point is going in brand new with a center starting off saying we're gonna test all of these things. You're kind of hopefully going to land with some tried and true. We try this is what we use. And again, hopefully you have a good dietitian who's taking these recommendations and others from the literature and developing a protocol. So it would be more, I would say, from a surgeon perspective, supporting that you have a dietitian and that you have enough to deal with all of this, and really working with them on these protocols to both empower them to be the person looking at those labs and identifying deficiencies, and then supporting with reinforcing that with patients that you're seeing about taking these supplements. Post-operatively, the recommendations here from that paper are to check within the first 3 months with iron. Again, iron is so tricky, and everybody, I would say, pays attention to different indices. And so, you kind of have to take what's available at the time, but keep looking at the literature. And it's not impossible to change which measures you're checking. And then every 3 to 6 months, checking on iron, thiamine, B12, folate, and D, annually here with your more comprehensive panel. And then, of course, the recommendations have been, as you touch the intestine more, you want to probably check and supplement more, given the possibility for deficiency. And then I put here, again, we could talk a lot longer about all of this, but as far as symptoms go, I think for these in particular, looking at nausea, vomiting, cardiac failure, and SIBO, when you're suspecting B1, that would be more likely to present in that way. And then I thought this was really interesting with B12, and I don't know how much we learned about that early on, but some of these medications, most of our patients are on, not most, many are on metformin prior to surgery. A lot of them are on PPIs after surgery. So those can exacerbate low B12. But again, as you heard earlier, it takes a long time to see that. And I think, that's just an interesting thought longer term, if they're on some of those medications, if they're having deficiency. And then, chronic diarrhea with zinc. So that's just really a really small snippet of some of the ways I think looking at symptoms first might be helpful. And then another good chart here, this would be sort of your general supplement recommendations to prevent deficiency. So that would be like for all of your patients until you have lab work saying that they're deficient in something. And these, some of these went up with that paper from prior recommendations. So I think the B1 is one that is much higher than we used to recommend. And, there's also all these caveats, right? So again, a lot of us want to have, and sometimes dietitians can be type A. I don't know if you've met any like that, but sometimes we want to have like a protocol that exists for everybody. But there's so many caveats, whether it be childbearing age women, which is like 80% of our patients, or people who have a DS, or, with iron, again, who falls into this category? Like men or non-menstruating women who can take a small dose of iron, or band patients. Most of them are in this. And I would say the iron levels are, those are concerning, and those do have some pretty, severe effects when people are feeling anemic and low with iron levels. Zinc and copper, there's that need for a balance with that proper ratio of zinc to copper. So we want to make sure that that's right for your patients who, just regular patients. So this part is where I think your dietitians are particularly helpful in looking at what are the available vitamin and mineral options out there. When I started in this field in 2007, I mean, it was like Citracal. It was the only calcium supplement. There's Bariatric Advantage was around, but really there's been so many more options over the past several years. So that can be both good, but also confusing to patients and to providers. Like, which one do you take? Are they all meeting these requirements? And I mean, I think my behavioral side would say, cool, if you have a really great supplement and the patient even can afford it, like, that's awesome. But there's so many other factors. And how does it taste? Are they having trouble taking their pills? Is it, there's so many of those more social behavioral factors than just you have a deficiency, here's the right vitamin to take, or you're just a patient with normal labs, take this forever and ever. It's a really tough thing to do for the long term. So then I didn't want to get creative on this section. I just wanted to put, some of these recommendations in front of you. If your patient has those signs and symptoms, or you're checking regular labs and you're identifying a deficiency, we have recommendations here. I also think it's important to look at what grade level these were, because there is not a ton of, grade A evidence out there for some of these recommendations. So a push for more studies in this area, I think, is important. But the biggest one, I think, with grade A is the vitamin D. So, for a insufficient vitamin D patient repleting with 3,000 to 6,000 IUs or the higher dose vitamin D2 is the grade A evidence there. And then using D2 over D3 when you can. The others, I think a lot of people would say you're going to have sort of tried and true in the practice kind of, on the ground treatment based on what people have learned over the years too, and what's available. So I'm not going to go through those individually, but there's, of course, Dr. Wilson covered several of the nutritional complications or considerations. There's others, and I do want to make sure that we have time for Q&A, but just to, kind of be thinking how you include, pathways for identifying and considering some of these other considerations and making sure it's a conversation with your team. I think for me, I talk about this a lot. The long-term follow-up really has to include some of these components. So again, we could talk a lot about how damaging I think it is when surgeons put a number in a patient's head about their ideal weight that they should get. I mean, your team is undoing that kind of discussion for years to come sometimes. So I think at this point, we've really, tried to embody the best weight that you can achieve while living the healthiest life you can enjoy type of approach. I really like that concept, because we all know, even for yourself, you can do all sorts of things and achieve a certain outcome, but are you balancing that with all the other components of a healthy and balanced life? And so that applies to our patients. We're not looking for perfection. And then I love this because we often see people who are like telling their patients goals and telling them what they should be doing. You get a paper and you get some guidelines and it's like, here's what everybody should do. But that patient-centered approach really means incorporating that person's individual goals and their preferences and values and all of that. And so that's a little bit harder than just a blanket requirement or a book or a binder or something where you tell everyone, here's what you have to do. And I really can't state enough, just sort of empathizing with the struggle. Like, this is just really hard to do for the long term. And I think hearing that sort of can help them think you're not up on this pedestal saying, here's how it is and it's easy. Like, you can recognize that it takes a lot and it's really hard. And again, remembering it's not all about you. It's about them. So making it comfortable for them to bring that to your attention. These are also, I would say behavior and nutrition are pretty closely intertwined. And often, I don't know how that evolved, but there's way more programs that have constant dietitian follow-up without the behavioral health. And I think we need to really move to where behavioral health support is almost as embedded as the nutrition support, because some of these are pretty impactful. And, I put this here also to say your dietitians may be the ones hearing this, your nurse practitioners, APPs, all of your people who are doing the long-term follow-up, if that's not you, are really hearing some of these behavioral outcomes or things that might be red flags to get more help. And so you want to be sure that they're supported in getting help for some of this, the body image stuff, coping strategies, alcohol, all of this aftercare is so important. And I ended early, but my end is patient-centered care really is about a culture shift for some of us, but it's about trust and respect, and it really involves not just the most recent evidence, but the patient experience, the person who's having to follow all these guidelines, their patient, their family, their culture, where they're going back after they leave your center, and it really does help with burnout and, satisfaction with your job when you're able to sort of balance that with what you're recommending.
Great job, Dr. Crowley, as always. Wonderful session, both of you. I'll ask the first question, but we do have a few coming in through the Q&A. And this is for Dr. Wilson. Small bowel length can vary between a little over 100 centimeters to over a meter. Do you routinely measure your limbs in the operating room?
Yes, I do, but I wonder if I should change my practice. So for my bypass, I kind of as a standard make a 100 centimeter biliopancreatic limb. And it's really an estimate. In my training, I did measure exactly 10 centimeters and measure the bowel out, but 100 centimeters for my BP limb and the roux limb, 120 centimeters. But
the common channel, everything else?
The common channel, no. And we've talked about here potentially looking at should we create our limbs based on percentage of bowel length totally, and take that extra time to measure from the terminal ileum to the ligament of Treitz, and then from there create our BP limbs and determine our length. So that's a great question, but I kind of do the standard 100 BP, 120 roux, but measuring the common channel may be, I think, something that's worth doing.
Yeah, unfortunately, the measurements aren't very accurate, and that's been studied. A follow-up question. There was a study by Avano a number of years ago where he looked at meat eaters versus non-meat eaters, and the meat eaters had much less nutritional deficiencies than the non-meat eaters. As more and more people are vegetarians and vegans, do you change your approach on one of those patients?
I have not, and I've not considered that, to be honest, or delved into it. I can't say in my preoperative evaluation and appointments, I'm digging into their specific diet practices and changing anything based on that. That's a good point, but I'm not personally really considered that.
Okay, Laura, do you want to fire away?
That was some great questions. I really appreciate that. I actually just saw a patient who's vegetarian yesterday who's having some issues with nutritional deficiencies. So we have a couple questions in our Q&A. The first question I think can go to both of you. And it is, can you address the impact of COVID necessitating virtual appointments, whether or not you see this as a practice here to stay? And how does this affect your assessment of nutritional deficiencies?
So from my perspective, I have been both, I think I'm more excited about some of the ways virtual has been able to integrate into our program. Specifically, delivering our education class through a virtual platform has been very helpful. I think, for so many of our patients, like we're in downtown Charleston on a peninsula, driving down there's annoying, getting into the building's annoying for the staff and the patients. And it's just really been, I think a lot of people have really appreciated being able to watch that at home on their own. It does make assessment of understanding of that a little bit more difficult, but I would say we never really had great methods of assessing understanding anyway in a group setting. It was a lot more based on, oh, do they look like they're paying attention? And that's judgment, not actual evidence. And so even testing with, didactic type questions after a educational session isn't really telling you all you need to know. So I guess for me, the virtual component of delivering education, I don't know that it's better or worse, but it's been keeping patients in the pipeline and able to have surgery. So I think that's been a really good thing. And then for visits, I've seen so many people's programs get really creative with how they're seeing patients. One thing that we've done in our program that I can share is we moved our 3 and 18-month visits, which were not required by the registry to be a medical visit, to actually a integrated behavioral and nutrition visit. So they see the dietitian and the behavioral health provider, and that has been virtual, which has been great because it was always a tough time getting those providers in the clinic room on a busy clinic anyway, when they needed to spend a little bit more time. So that's been one way. And, the behavioral health has been billing, I don't know if the dietitians are, but they're really seeing a lot more patients and making that that's just part of the program. Like I said, with behavioral health, I really think we're not optimizing our programs when we're not having people see behavioral health as just not when you're, really needing it as a saving intervention, but just it's hard. You're adapting things, how are you adjusting to surgery and life after surgery? I think that 3-month time is a nice time to do that. So for us, that's been a way COVID has helped our virtual kind of integrate in the program. And I think for us, that's going to be here to stay.
It would be interesting to see if we lose less patients long-term, because the virtual visit is so convenient as opposed to, like you said, driving downtown, parking for $20, leaving work. It's just so much easier and comfortable for patients that I wonder if they'll be more prone to stay in your program as opposed to disappearing.
Yeah. Well, I think providers also who are, oh, we don't like the visit because we can't have, the connection, or people are distracted. Again, I think there are some really good studies. I don't have them at the, top of my mind, but there's some good studies showing similar outcomes. So I think there's a difference between a preference for something based on how you like to communicate and actual evidence for, is it keeping people where they needed to be? And I think offering, just like you would any, offering patients the way that they want to do it. So you have people who prefer in person, making that available to them and not having it just be, this is the way we treat every patient every time.
All right, there's another posted question. Do you have a recommendation for any specific additional zinc supplements for those long-term follow-ups who are taking all of the appropriate postoperative bariatric vitamins? We've noticed a pretty big increase in low zinc levels in our clinic. Like you said, zinc is super important. Anybody have a recommendation?
Yeah, so zinc, from the most recent guidelines, it doesn't look like there is a set treatment dosage for zinc with a deficiency. And so I think you have to think about what they're taking and then increasing that, and then following up with some lab work to see how that's doing. I think back when I was doing this more regularly, they're getting those ratios of copper and zinc is easy if you're using bariatric specific products, but when you're, having people just go to the regular grocery store or Amazon or whatever to order their vitamins, that's trickier. And a lot of the hair, skin, and nails formulas would throw zinc in there without copper. And so, I think that it's important to think about that. And a lot of patients who are thinking that their hair issue is a nutritional deficiency, it may not be. They're throwing extra supplements at that, but not considering some of the other ones. So I think there's some, lower dose 50 milligram zinc supplements that would probably be the first line when someone shows up with a low zinc. I don't know about increasing it across the board to everyone. If you're seeing trending low levels in your patient population, I would say that still should be individual lab work and a treatment plan based on the person.
Okay.
Excellent.
All right, another question. For patients with cholelithiasis that had symptoms previously, do you recommend prophylactic cholecystectomy before bariatric surgery or concurrent at the time of bariatric surgery?
Mm-hmm. In our practice, we get ultrasounds prior to, as far as the pre-op workup through the program, but I do offer cholecystectomy at the time of the operation for weight loss. Now that can be challenging sometimes depending on how the case goes. When you do multiple procedures in one setting, your risk of complications, maybe infection, goes up. So that's something to consider. So, but if they're symptomatic, or one of my patients had a gallbladder full of stones, so she really wasn't symptomatic, but I thought it would be better to take it out at the time. So I will offer it if they're symptomatic. And I would just say, I do a cholangiogram in these cases because that's the last time you can do a cholangiogram easily before the anatomy is distorted for a bypass.
And if they're asymptomatic with a couple of stones?
I leave it. If they're asymptomatic, then I don't offer the cholecystectomy.
Okay. Laura?
Yeah, so there's a question for you, Dr. Crowley. Low carbohydrate diets permeate the bariatric world. Do you recommend transitioning to a more Mediterranean style diet or a balanced diet 6 months to a year out from surgery?
Yeah, that's a good question. So I know we talked a little bit of, there was a question about macronutrients. And I think that's one of these things where, again, we're looking for guidelines that are more prescriptive. I always say, like, I started as a dietitian thinking it would be easy to just learn this science-based thing and tell people it and how to do it. And then I literally had to get a PhD in psychology to be a better dietitian, because I started learning so much more about, compliance is not just telling people what to do and having them follow it. And, the motivational interviewing stuff and the patient-centered care, all of that is so much more important than I think we learn when we're learning how to, get the right eating pattern to the right patient. So I mean, in my practice, we didn't have a very, this is a specific gram of carbohydrate not to go over type of a style of eating, because just like vitamins, telling people this is the perfect doesn't necessarily help them get there. So I think, in my opinion, it's much more helpful to get the individual patient where they're at, what they need help with. But of course, you do need some guidelines. And I know that, they are lower carbohydrate than probably the patients prior to surgery. So I guess it would just depend. I don't necessarily prescribe or recommend a specific style of eating to the patients. And I know what I do think in that category is I think we should be more open to that. So when people come and say, I'm doing intermittent fasting, I'm doing keto, I'm doing low carb, I think sometimes, and some dietitians would say, oh no, don't do that. Or I think a lot of the medical providers are like, oh yeah, this worked for me, why don't you try this? So if we can try to take the personal out of it and kind of go back to, if it's someone who is eating a high amount of carbohydrates, well, then individually they would maybe come back off of that, and that would be individualized to the patient. So that's sort of where I would go. But I also think, longer term, their eating is much more normal than I think people think going into it. And sometimes people are recommending when you're talking about specific tiny portions. I think again, back to normalizing the patient experience. If you're telling them, here's your diet post-op forever, and it's, 1 ounce of chicken and a quarter cup of vegetables, well, when they're eating more than that, they're feeling a little bit like, oh, I'm failing. I'm not doing it. I've regained a little weight. Well, they told me what I was supposed to do and I'm not doing it. So there's sort of that cycle of, sort of, I don't know, behavioral thinking of, okay, this is failure. This is not good. And so I just, again, can't say enough how normalizing the experience, talking to other people about it, but also individualizing their plan. And Kim posted a question about body composition. I mean, that was another way for you to individualize their care, right? So we know that just measuring weight and BMI is not all that helpful. And in my practice, I think of my sweet older ladies who try so hard, they try the hardest, and their weight maybe isn't budging. And so I love that we can have some other tools on how to help them measure progress, and maybe they're protecting muscle mass instead of losing that as they age. And that's a really good goal. So I think that can be integrated into some individual behavioral goals for the patient, and showing them success, because they're all so accustomed to that stupid weight and number on the scale that part of our practice is just pulling away from that as the only measure of how you're doing.
Luis Reyes asked, any input in the treatment of perineal nerve syndrome? Anybody have any experience with that?
No, I can't say that I have specific experience, and I would certainly refer to our specialist colleagues to help.
Yeah, right behind.
I went flat like my screen's frozen. I don't know the answer to that. I don't know anything about that. So I would let my doctors talk to the patients in that case.
How about bone density testing? I know you spoke about it. Do you have a protocol for what age or how many years out from surgery you think a woman in particular should be tested? How often?
I think I think based on age, especially at-risk populations, those who already have a diagnosis of osteoporosis or calcium and vitamin D deficiencies, or elderly patients, I think a pre-op getting a baseline DEXA scan is good. And then I think 2 years post-operatively, I've seen in the literature, and then thereafter kind of on a regular basis when they're being supplemented, but following them, at least getting the baseline 2 years post-surgery, and then according to guidelines, just measuring and keeping up with that is important. Yeah.
Especially given how important that calcium and vitamin D is, and how that tends to be the ones that drop off, I think, because they're cumbersome or too frequent. We didn't have a specific protocol for that. I think we could have been stronger on that category. One thing that always stuck in my head when we met with some folks in endocrine or that area was that they said measuring on the actual same machine for DEXA scan is important. I don't know that I've seen that in the literature of how accurate that is, but I remember hearing them say it's important to kind of go back to the same actual equipment for testing if you're measuring it over time.
Interesting. There are no further questions from the audience. Does anybody on the panel have any questions?
I have a burning question. One of the most common comments I get from patients is concern, both pre-op and post-op, about hair loss. How do you counsel patients about either prevention or treatment, and what do you recommend?
So I cut that slide, but I could talk about that. I think the biggest, I think it's one of the things that freaks people out the most. And it really is, thinking about recent events and how hair is so important to our identity and our, personal, opinion and psychological components of ourself and self-image, I think it's important to talk about preoperatively, because if they don't have that sort of expectation, it's scary. And then they go to the internet and find all the, vitamins out there, not the bariatric companies, but they're targeted to specifically, hair, helping you with hair loss. So I think the way that we did it, we had a component of our pre-op class where we talked about that, and that it can be, considered normal. I think really looking at more the stress of surgery and the anesthesia and the sort of medical component of when hair loss can happen, that's sort of more normal immediately post-op and up through, the first year, versus it's just starting now 2 years post-op being more of a nutritional deficiency. So, I think it deserves a sort of medicalized discussion first, and then if it does seem to be, more of a nutritional deficiency, kind of looking at what that might be related to, because it could be different things. It's not necessarily just, take biotin and your hair will come back. And so there is sort of that talk about and I can't remember it, but the anagen and the telogen, like the different phases of hair growth. So I think that's helpful to maybe put in your education about how hair growth happens, and some of the vitamin supplements out there to help with hair make the strands you have thicker, stronger, shinier, and that's different than like actually promoting regrowth. But again, just like with, I think, like the plastic surgery conversation about, those are the things I think are really important part of that informed consent, because there's patients who, loose skin or hair loss after surgery would be enough to make them maybe not even consider the benefits of weight loss if that's so core to their identity.
There's another question that's posted in the literature regarding insulin-sensitive hypoglycemia. The recommendation for use of cornstarch, although no doses, and then in questions 1 teaspoon per food. Have you used cornstarch? I haven't.
No, neither have I. I haven't seen that as a treatment regimen, a part of it.
All right. Along those lines,
I haven't either.
If I could ask you, Dr. Wilson, if you had a patient with intractable hypoglycemia, you talked about as a last resort reversal, which is absolutely true, and they can be very challenging, and the complication rates are not insignificant. Have you considered putting in a gastrostomy tube in the fundus and feeding them through that to see if the symptoms go away, to make sure that's the diagnosis?
I think implementing that strategy before full-on reversal is a worthy consideration. Like you said, it's not insignificant to do a reversal. So I do think employing something like that, if it's feasible, of course, sometimes it can be difficult, hostile abdomens and things, but I think if it's feasible and testing that, that may be optimal. And then even giving them a nutritional head start, getting the feeding tube in and bulking them up so they can be ready for a reversal if needed. It's good.
And if they don't respond to it, then maybe that's not the diagnosis.
Right. Correct. I would explore all those options and get consultants, endocrinology help too, to really figure it out, because it can be tricky.
Yeah.
And I would just add, cornstarch is making me think about something I wanted to talk a little bit more about. I know we don't have time too much, but with pica and iron deficiency, I mean, that's one of those, that's a true interdisciplinary issue and problem, and both figuring it out and how to treat it. So I would also say having questions that aren't like shaming questions about that behavior, because it's really complicated how it's nutritional and related to iron deficiency, but it's also sort of a behavioral and almost cultural issue. So we've done some studies years ago with someone who that was their specialty, and I learned so much about just how complicated that is. But asking the right questions, I think our dietitians end up hearing most about that, because sometimes it is food related. And I mean, one of my interesting patients who had pica was they were chewing those sublingual B12s, like several of them a day as a pica behavior. And so I don't even remember how I figured that out with them, but it wasn't the typical, like, do you eat dirt or clay? And sometimes those closed-ended questions don't allow for that true answer to come. And that would be a real medical, nutritional, and behavioral problem.
All right, Laura, anything else? Any questions?
No, I think this was 2 really wonderful presentations. Thank you both so much. I learned a lot, and the questions were excellent as well.
It was a great session.
Yeah, thank you all so much.
Thank you guys for having us.
Thank you.
And see you in the afternoon.
Everybody. Have a great weekend.
Yes, and a Q&A session this afternoon for the West Coast attendees.
All right. Bye, everyone.
Thank you. See you later on today.
Bye.
Hello, everyone. I am S. Julianne Lloyd. I'm one of the moderators. I guess I'm the only moderator today. My co-moderators are taking the FPD exam, and I wish them and everyone who's taking the exam this week all the best. But first, I'd like to thank both of our presenters who have given stellar presentations today. Very, very good recap of all of the nutritional requirements and all the things that can potentially go wrong with our patients. At this point, I would like to open it up. It looks like some questions are coming in, so we'll go straight to the Q&A. The first one we have from Karen Schultz is to Dr. Wilson. How often do you think surgical technique is a factor in sleeve dilation or herniation over time?
Yeah, I think that's a great question. Certainly during the operation, there are things that we can pay attention to in terms of shaping and sizing our sleeves that can set the patient up for success or leave us wondering if our technique has maybe compromised maybe their outcome. So how wide you leave the antrum versus how wide you leave the top of the stomach as you're stapling across it matters, or making sure that the line is kind of straight going up the stomach as we create the sleeve and there's no twisting. Over time, those can lead to symptoms like especially reflux heart disease and or lead to kind of nausea, bloating, things like that. So I think there certainly are things in the operating room we look to do to make sure the shape of the sleeve is appropriate. Sometimes taking like the antrum, some people have gotten away from that and they take less of the antrum, especially on the bottom portion, and they just kind of go straight up. Other people like to take some of that at the incisura angularis, but certainly some factors are in our control, and kind of as you learn and progress, I think people try to figure out what works and compare what their technique was to the patient outcomes. And other times it's hard to really predict what happened because we know studies have shown that there is an increase in volume of the sleeve over time in some people. So there are some things that we can be careful to do though.
All right, I'd like to ask Dr. Crowley some of the nutritional questions that are popping up here. So the first one from Dr. Reed, can B1 be covered in a multivitamin? Like, will patients get enough B1 from a multivitamin?
So it depends on the brand, of course, like everything. So there are some of the bariatric formulations that do have enough for the more recent guidelines. Most of obviously the over-the-counter thiamine is going to be, 1.52 milligrams, so definitely not enough. But getting over that 12 milligrams as a minimum, I think is hard to do in any non-bariatric formulation. So I think you're kind of dealing with piecemealing a whole bunch of things together to get the right amount, which can be, cumbersome, or finding a bariatric formulated vitamin that really works for the patient, given like cost and taste and format of the vitamin.
So you guys both mentioned thiamine deficiency, and Dr. Wilson in particular talked about the importance of recognizing it. How often are you guys seeing this in patients who come back to practice?
For me personally, I haven't been down in the clinic recently, so I don't know, how often the dietitians in our group are seeing it anymore. It's pretty rare that we're seeing it clinically presenting. I think we'd more see someone who came in, got their lab work drawn after the appointment. I think that's always it's a practice consideration, right? Do you get them to come ahead of time so you can review them with the patient in person, or do you do them at the visit and have to follow up after the fact? So I would say we would see it more often where they came to the visit, got their labs done, and then we reviewed, and it was either, subclinical or, just slightly trending low. I don't know prevalent in our practice. I don't know if Dr. Wilson does in hers.
Yeah, not often. And it's because every time someone needs an outpatient IV hydration appointment, they're getting some thiamine with their banana bag. We're just going to give it to them like candy. So we don't see those clinical manifestations because we are so vigilant about knowing the seriousness of deficiency when people do have it. So I think we see it less. I remember in my fellowship, I saw one case where a young woman, similar to the case presentation I had, got her gallbladder out, persistent nausea, vomiting, and she actually ended up having neurologic manifestations and B1. And we were able to then retroactively question her and realize she wasn't really getting or tolerating her supplements. And so we don't see those clinical manifestations, but I think it's because we're better about repleting them empirically.
Yeah, you're absolutely right. Like when patients come into our ER, that's usually one of the first things they get, as well as a banana bag. All right, so we'll take another one from the audience. Would you be able to expand on how the post-op dietary intake affects these vitamin deficiencies, or is it all about supplementation?
So I think that's a really good question. It's definitely, I think it's a combination. Obviously, we don't want to only rely on supplements to get those items in the body. It's just such a variable intake. And I think it really doesn't, I don't know that on the individual basis, we have a really good estimate of what someone's daily intake is. And so I think also, as you kind of heard my practice, we're getting away from being super critical and nitpicky about their actual exact macronutrient intake, because we're using more of our time to work on some of the sort of behavioral aspects of eating after surgery. So I don't know that we're doing a true, assessment of their, caloric or macronutrient intake that you would say, oh, well, you don't need, this much of the food. So I think probably calcium would be the one area where you might be able to say, well, this person has a really high dietary calcium intake, and maybe they can, have a little flexibility on their supplementation if you consider their lab values as well. But I would say for almost all the other, the water soluble, the fat soluble, and probably even iron, they're not really getting enough in the diet to say, take that out of a vitamin, especially with the multivitamins kind of expanded to be more of a bariatric formulation. You wouldn't ever get rid of one of those if they had a high intake of a couple nutrients. And we're just not a consistent enough species to really be the same every day, in my opinion, either.
Yeah. When you mentioned just now the calcium, it actually reminded me that most of the patients, we have to give them specific instructions on how to take them as well. So the calcium, for instance, they have to wait a couple hours after taking the multivitamin before taking that. And it just really underscores the importance of having a multidisciplinary team, because that's something that the nutritionist will not forget to tell the patients, but probably as a surgeon, it may not be at the forefront of our minds as we're talking to them about the specific procedures.
Yeah. And like I said, I think is in practice, when you're starting out, I think we definitely, I remember starting out feeling very idealistic about here's what we should do. And then I would say almost every patient, you have to kind of negotiate a little bit about what are they able to do. And so calcium, I think, is, there's some ways to get that in, that everybody sort of has a different way that they're interpreting and taking those supplements. So yeah, underscoring the fact that, I don't mean to minimize what the doctors are doing with the patient, but just, use your time to do those things. And like you said, the dietitians can use their time to really take all of that into play and really consider the whole person there.
Okay, Dr. Young asked, if a patient has low iron levels on the pre-op testing, would that change your recommendation for the type of surgery, a sleeve versus bypass, due to the risk of worsening anemia?
Well, I think it would certainly be important to investigate why those levels are low. Is it, they're menstruating women who just need supplementation, or are they due for a colonoscopy and haven't had one, and we need to work it up further and maybe delay an operation until we can figure out why they're anemic and maybe correct that. So it certainly affects the timing. The type of operation, not necessarily. I think type of operation may depend more on their surgical risk, how fit they are for surgery, medications that they have to be on, biologics, immunomodulators, anti-inflammatory disease. That would make me change an operation, but I would just do a workup of the anemia first. So I would delay the operation until we knew.
And I think from my perspective, we've had patients, I would say the real severe patient with pica or, needing iron infusions, that would maybe be a consideration, especially if, they come in, and it kind of is timeline, right? So for us, it's the surgeon would be in there talking with the patient first. Oh, you're a candidate for the DS, maybe given your weight or, goals for comorbidity resolution. And then the dietitian goes in and would say much like, oh my gosh, no, given all these things, that is not a great option. And at least our surgeons have been very flexible with the approach of, okay, this is a team approach, given everybody's input, this might not be the right, type of surgery given that. So I think that would be more but again, if you're seeing them in person, then they're doing labs, then you're treating that. Do we check the labs again before surgery to see if that's up? And it does underscore the need for sort of those interdisciplinary roundtable type meetings. And I know, we'd love to have them on every single patient. We tend only to do it on people who've been identified as a real problem for some reason. And so it's tricky.
All right, one more from the audience. What's the incidence of SIBO that you guys are seeing in your bariatric populations?
I can't say that I've seen SIBO often, honestly, just in my brief time and then in fellowship, but there certainly are complicated patients. And sometimes we may not know about SIBO and even know to try to look for it or diagnose it. So we certainly have seen patients with some type of intestinal insufficiency. They're struggling, malnourished, and they need to end up being reversed. And so a lot of it may be underdiagnosed because we don't know to look for it, and we may attribute it to other causes. So I think the incidence may be lower in sicker patients than we realize.
I'd say the same. I've had a handful of patients over the years that we've figured that out, but it's definitely, it takes someone who's looking for that and knows about that to really figure that out. And then, we've had experiences where we've referred to our GI medicine folks, and, maybe they didn't know exactly what the treatment was, or the medication was one of those expensive or needs a lot of prior authorization type medication. So I think it's low, but higher than what we're actually seeing.
Mm-hmm. All right, so just scrolling back up, there are tons of questions to you guys. That's just a testament to what an awesome job you did today. It's really stimulating all this discussion. But there was a question as to whether or not their patients are requiring parathyroidectomies after surgery, especially if they've had kidney disease. Can you comment on any specific nutritional recommendations or resources for these types of patients that have renal issues?
That's like my weak point. And so I know when the recommendation came to really check the PTH with lab work for sort of the calcium vitamin D pathway, our nurse practitioner and dietitians were like, oh, we hate this because it's really hard to know what to do with those lab values. And then I said, oh, I'm the coordinator. I'm out of that discussion. So good luck with managing that, guys. So, and they're not here to defend themselves. And so, but I do know, like the morning session, there are tons of my integrated health colleagues on here that are much more integrated in the practice. So I'd love if, either in Q&A or chat, if anyone wants to comment on that in their practice.
Yeah. Yeah, I know it's certainly part of the kind of order set for labs that we check at least at 6 months and then annually. And then pre-op people get that. So I don't know what the incidence is and how many folks develop secondary hyperparathyroidism or if they already have renal issues. But it's certainly a benefit to be in a place where you can easily refer to your endocrinology colleagues for treatment and evaluation. And if they have renal issues, nephrology, we do get quite a few transplant patients where we need to work closely with others to optimize the patients for surgery and so they can continue treatment. So I don't know how many people actually suffer from secondary hyperparathyroidism after our surgeries because of deficiencies, because we do a good job about following and correcting it. So.
And I would add too, I think another, as you can tell, I'm in the program coordinator mindset where the biggest thing for me is communication between the bariatric program and the endocrine folks that we're referring them to, because this could be one of those areas where we're checking a lab, we have a parameter, then we're making a referral, they get the patient and like, what do you think we're supposed to do about this? We don't know, and sometimes you can get that kickback of, who's managing this? Oh, it's a bariatric patient. We don't want to touch it, depending on where you're at. So I think that just like dialysis centers and transplant, I think it's really good to have those conversations up front and say, we're going to be checking this lab based on which parameter are you comfortable seeing patients? And then really, what are you going to do? Because it's one of those things, oh yeah, we check that, but well, what's the protocol and what are they doing with an abnormal value? Because that patients that have access to their medical record see a lab value out of normal range and will start those messages of, what does this number mean? And I think that's a, patient satisfaction thing too, of, having a good answer for them so they know, really that what you're doing when they have a lab value out of normal range.
Do you guys ever worry about vitamin overdose? And if so, is there like one particular component that you're worried about?
The fat soluble vitamins are obviously the ones that, we would be more worried about an overdose. So like a vitamin A in a pregnant woman or, sometimes with those high doses of vitamin D. Overdose I don't know the overdose component. We used to say too many of the water soluble vitamins makes for expensive urine, right? Because you're, getting rid of it that way. So I would say you'd be looking more at the fat soluble ADEK or the minerals. I don't know that anyone can really overdose on the calcium, just given that it's so much and hard to take. But iron is one that I think is a little trickier. The copper and zinc can get, out of those ranges. And I think I mentioned, I don't know if it was in the Q&A earlier or in the talk, but a lot of those hair, skin, and nail formulations that people take when they assume hair loss is related to a vitamin level, the marketing around hair, skin, and nails formulas is much stronger than around bariatrics. And so they may take something that has a lot of zinc in it and take too much zinc and drive their copper levels down. So it's pretty nuanced and pretty complicated to get all the levels right.
All right, so we do have a couple more questions remaining, but unfortunately we're so far over time. I really do appreciate the time that you guys and really the effort that you put into preparing the presentations and delivering them to us. We're very grateful for all of your knowledge today. I'd like to thank the ASMBS and our panelists in particular And I guess we'll join you guys again next month for another session.
Thanks, everybody.
Thanks, everybody. It was a pleasure.